That's nutritional support in trauma. Most people don't appreciate this, but 25 to 50% of patients that are admitted to hospitals in the United States have previous nutritional deficits. And approximately 25 to 30% will develop malnutrition if they don't have malnutrition already at the time of admission. They will develop malnutrition during their hospital stay. We are really focusing on this morning on moderate and severe malnutrition, and suffice to say that if our trauma patients are malnourished, they will have increased number of complications, particularly infectious complications related to delay in wound healing and other problems, and also there is an increased mortality associated with malnutrition. It's important to realize that the trauma leads to a hypermetabolic state. There is a change in the metabolism, and the body tries to protect itself, producing glucose, breaking down protein, and breaking down fat. This hypermetabolic state lasts days to weeks, depending on the injury severity, depending on the premorbid conditions, and as well as the nutritional status prior to the moment of the injury. Who should receive nutritional therapy? I think that's the first question we should answer. Obviously, those that come in, they are previously malnourished, they should receive the aggressive nutritional support. In general, patients with severe injuries will be NPO for some time, and most people would agree that keeping a well-nourished patient NPO for about 5 days is probably okay. Those that you anticipate are going to be NPO for greater than 5 days, you should start nutritional support earlier on. And the objective is to maintain organ structure and maintain organ function, obviously to treat malnutrition when it's already present and prevent specific nutritional deficits. Why is this important? It's important because the body needs to fight off infection and this exacerbated inflammatory response that occurs after injury. So energy production is really important, protein synthesis is important, and we need to minimize nitrogen losses and protein breakdown. I'm sure that most of you that deal with trauma patients in intensive care unit have seen patients that come in, they are well nourished, and over their hospitalization they lose muscle mass and they lose weight, and we see these people deteriorating from the nutritional standpoint in front of us. There are several ways we can calculate how many calories a patient will require while you're in the intensive care unit. This is just one example, the Harris-Benedict equation for males and females, and what it gives you is the basal energy expenditure. So you get a number, and that number means the amount of calories that you require, that are required for your cells to work and for you to stay alive if you are laying in bed and not doing anything. In addition to that, you have to add a stress factor depending on the severity of injury and many other things. And basically in trauma, we go from 1.2 to 1.5 or 50% above the basal energy expenditure. If you go to the burn unit, burn surgeons are very aggressive in providing nutritional support to major burns, and those are the most hypermetabolic patients you're going to see in the hospital, and in some units they double the amount of calories calculated by the Harris-Benedict equation. You can do that using direct calorimetry. We do that in our burn unit, and it seems that there is a very good correlation between the calculation of basal energy expenditure using the equation and using the respiratory coefficient. Now I would like to bring to you some evidence-based guidelines and discuss some of the controversies that are still present in the year 2005. The first one is obviously enteral and parenteral nutrition, and I think surgeons have been discussed this for many, many years. I think that in terms of parenteral nutrition, it's clear today, and there is data supporting higher infection rates in patients that are supported by parenteral nutrition. Obviously, if you don't use the gut, there is a breakdown in intestinal mucosal barrier, increasing gut permeability, and perhaps increasing bacterial translocation, leading to sepsis. In terms of enteral nutrition, so everybody or most people will agree that enteral nutrition is preferred if possible. However, just giving a little bit of enteral nutrition won't do it. And most patients often don't receive enough enteral nutrition during their first week in the hospital or the first week in the ICU. And there are several problems associated with enteral nutrition. Diet intolerance is one of them. Some people don't tolerate the diet that they are receiving. Increased residuals, they have prolonged ileus, or they develop diarrhea. So at the end of the day, you gave enteral nutrition, but you didn't give enough. What's the evidence to solve this controversy? The evidence is obviously in favor of enteral nutrition. There is level 1 data, particularly in severe traumatic brain injury. Early enteral nutrition has been supported in the literature. However, parenteral nutrition is acceptable if enteral nutrition is not feasible for traumatic brain injury. If 50% of enteral nutrition goal is not met at the end of the first week, parenteral nutrition is also a possibility. So that patient will receive enough calories with the combination of enteral and parenteral nutrition. So it's really important that not just give enteral nutrition, but you got to monitor how much you're giving, how much the patient is taking, and you may need to supplement that with parenteral nutrition by day 7. The other controversies in terms of enteral nutrition is when to start it, early versus late. And there is some data in blunt and penetrating trauma. And the first controversy really is regarding the definition, what's early and what's late. The definition varies from 4 to 72 hours. In fact, there is no significant differences in outcome if you start enteral nutrition at 4 hours after injury or 72 hours after injury. However, there is no consensus. The data interpretation is very difficult. This is a mixed bag of different types of injuries, different physiologic arrangements in this patient population. But in general, there is a decreased incidence of infections if you start early, no survival benefit, no decreasing length of stay or ICU stay, diet intolerance and diet composition, there are problems. Access to the small bowel is a problem. The amount received varies, so that makes the data very, very difficult to interpret. It seems that there is some data that's level 3 data showing that the presence of shock usually delays enteral nutrition, and patients that need enteral nutrition the most obviously are excluded from these studies. Data is a little better in burns in terms of early versus late. Data is more consistent. There is increased diet tolerance in the burn patient, and the recommendation is to start as early after injury as possible, and that's level 2 data. In terms of nutritional requirements, there are very specific guidelines. Obviously, in burns, the energy requirements depend on burn size. In head injury patients, usually these folks are hypermetabolic, and however, depending on how you manage severe head injuries, you may need to decrease the amount of calories that you are providing to those patients, particularly if they are paralyzed using neuromuscular blockade or phenobarbital coma, because now you have a paralyzed patient and the energy expenditure will drop. The same applies to spinal cord injury patients. If you are quadriplegic, you need less calories than if you are a paraplegic, and then you need less than if you are moving all 4 extremities. So there's decreased energy requirements according to the level of your spinal cord injury, and you need to take that into account when you write your orders. The current recommendations for trauma in general, 25 to 30 kilocalories per kilogram per day, or 120 to 140 of your basal energy expenditure. So as I said, you calculate the baseline and then you add a stress factor depending on the injury severity. You should not give more than 1.25 grams per kilogram per day of protein, 2 to 4 of carbohydrates, less than 30% of total calories in form of lipids. And this is all level 2 data, but at least gives us some direction. In terms of burns, data is better, and again, you give more calories estimated for trauma patients. For traumatic brain injury, 30 kilocalories per kilogram per day. In non-paralyzed patients and in paralyzed patients, you got to drop that, as I said. For spinal cord injury, the same concept applies. For quadriplegics, 55 to 90% of your baseline. For paraplegics, 80 to 90% of your baseline. Immunonutrition, we are talking about non-essential amino acids, glutamine and arginine. These are diet components that may change the inflammatory response to the same extent that Dr. Hoyt showed the fluid resuscitation affecting the immune system. It seems that this affects the inflammatory response. The data is very confusing. The results are mixed. There are differences in patient populations, diet composition, time of initiation. So it's very hard to interpret and figure out if this in fact helps trauma patients. The conclusion is, though, that there is no difference in mortality if you give a patient immune nutrition or a regular enteral nutrition. And there is some data out there, however, that suggests that if you're going to downregulate the inflammatory response using immune nutrition, you should use in patients that are not infected, that are not septic, because when they are infected, they need to have their immune system activated to mount an inflammatory response that's able to fight off infection. And there are 3 studies out there that showed increased mortality when immune nutrition is used in patients that are already septic. To conclude, starvation is bad. If the bowel works, use it and use it early. If the bowel doesn't work, TPN. Ileus is gastric and colonic and won't prevent you from using an enteral nutrition strategy. There's several ways you can feed the patient: gastric tubes, post-pyloric, G tubes, J tubes. Immune-enhancing diets are okay in non-infected patients, and avoid overfeeding. Thank you very much for your attention. Speak to the